Okay, everyone, thank you very much for joining us this evening. This is the second webinar of Professor Angelo Cardarelli with us, AB Dental. It's very nice to meet you all. My name is Irit, and I'm the VP of Marketing at AB Dental. The next webinar of Professor Angelo Cardarelli is going to be next week with all on X concept, and we're adding the registration link in the chat right now. You can already save your seat for next week and register in the link. If you have any questions during the webinar, you are more than welcome to write it on the chat, and at the end we will do questions and answers session, and the Professor Angelo Cardarelli will answer it. And I'm very happy to invite Professor Cardarelli to the webinar this evening on the ION conical platform implant. And you can go ahead.
So, hello everyone, it's a pleasure to be here again and welcome to this second online lecture. And today we will discuss about how we can use this new conical implant platform in our daily practice. As you know, in AB Dental, we have the possibility, in AB Dental System, the possibility to choose different implant, different shapes. And today we will discuss about the conical implant and how we can use in our daily practice for the single tooth restoration to the full arch rehabilitation. As you know, we have different shape, as I told before. So basically we have the internal connection, and the internal connection we can choose different shape according to the quality of the bone, according to our surgical procedure. What I mean, if we need to treat the maxilla, we will use more aggressive treats in order to increase the primary stability. Instead, if we want to use in the mandible where the bone is harder than the upper jaw, we will use a less aggressive treats in order to reduce the compression between the implants and the bone, avoiding any kind of bone resorption. And also the prosthetic part, it's different if we are talking about internal connection or conical connection. The very new interesting thing about the ION is the possibility, if we are using the multi-unit abutment, to use this new multi-unit abutment shape with the switching platform. And with this shape, we can manage better the soft tissue. And I will show how we can use in the full arch rehabilitation this kind of multi-unit abutment. So basically in my practice, I'm using I5, I55, I22, according to, as I told before, if we are treating the maxilla and if we're treating the mandible. As you know, I5 is more aggressive, so we can use better in the maxilla. Also, if we are doing crystal sinus lift. Why? Because the apex is smooth. And we can use I55, for example, in the mandible because it's less aggressive. But also now we have the possibility to choose this new implant. We have internal conical connection with the screw. And also the shape is very interesting because this shape, with this shape, we can achieve a good primary stability. That's why, for example, I'm using this ION implant in immediate implant placement, especially in the molar area. Why? Because sometimes we don't have enough bone septum, and if we don't have enough bone septum, we can achieve the primary stability using this kind of implants, using this kind of treats, more aggressive, so we can achieve a better primary stability. And also, with this ION conical connection, we need to place, according to the protocol, the implants 1.5, 2 millimeters below the bone. Is no bone level implant. That's why we need to prepare more. We need to put below the bone, and using the switching platform, we can allow the growth of the bone around the neck of the implant, as I will show in some case. So basically, this is the shape of this implant. And as you can see on the right side, we have this new multi-unit abutment. As you know, in the normal implant with the internal hexagon, usually we don't have this switching platform shape. But if we have the possibility to use this multi-unit abutment, we can hold the soft tissue around the multi-unit abutment to stabilize better the soft tissue. Because don't forget that we need to have enough keratinized tissue to prevent any kind of problem during and after the osseointegration. And we can do with this implant. So this is a short video about this implant. This is the shape. Connection. Okay, so basically this is the resume about the characteristic of this implant. And as you know, with the conical connection, we can have a better seal for the bacteria. This is another advantage that we need to consider. So let's start how we can use in our daily practice this ion implant, for example, in the single tooth replacement, in the single tooth restoration. As I told you before, I'm using now in immediate implant placement. If we have a case like this, lower jaw, fracture of the crown, we have this situation, so we can remove, but have a look. After the extraction, the bone septum is very, very thin. So how we can achieve the primary stability? Preparing the septum, but as you can see, the septum is not too thick. That's why we can use this implant. In that case, I use 4.2 per 11.5. And we can achieve a good primary stability, placing the implant in the middle of the bone septum, according to the protocol. And we can get around 40 Newton of primary stability. Then we are in the posterior side of the molar area. In that case, I filled the gap with some bone, and I did some sutures just to hold the collagen sponge in the residual socket. And this is the X-ray. So I placed the ion 2 millimeters below the bone. Then we can wait the healing and osseointegration. So after 3 months, we need to open again the implant. And we can put this healing cap for ion with this shape, okay? And we can take the impression. Obviously, for the ion connection, you need to have a dedicated scan body. So the scan body that we are using for ion are different compared with the scan body for sure that we are using for the internal connection. So with ion, we can use the same surgical kit. The difference are in the scan body, in the healing cap, and in the prosthetic part. And also we need to have a different tools in order to place the implant. Those are the only difference. But we can use the same kit that we can use for I5, I55. So only one kit, also for Ion, the same kit. Okay, so we can take the impression with this scan body, and then look, we can get this temporary. So as I told before, having this shape, we can manage the soft tissue. You can see the Ion after 4 months later. Okay, so you can see the connection, and you can see the conical connection, and on the left you can see the T-base for conical connection with the temporary crown. So as I told you before, also the T-base is different because it's for conical connection, and we can have this shape. So now we can screw our temporary like this. So this is the temporary, and this is the X-ray, okay, with the T-base. Have a look, the healing only 1 month later. You can see the soft tissue shape. You can see the amazing healing. This is the healing 1 month later after the use of the temporary restoration. So you can see the soft tissue shape. You can see the placement of the implant 2 millimeters below. So we can take a new impression for the final restoration, but the interesting thing is to see here the X-ray after the loading. Have a look here. You can see the growth of the bone on the neck of the implant. This is our goal, using the conical connection and placing the implant 2 millimeters below the bone. So we can have a better seal for the bacteria, and we can allow the growth of the bone around the neck of the implant, as you can see in this X-ray. This is the X-ray 4 months later after the osseointegration, okay? Then we can finalize the case with the final restoration, sorry. So you can see here the shape that I want to use for the final crown. So we have this switching platform T-base to allow a better healing of soft tissue, and a screw inside for the conical connection. This is the healing. And this is the final screwed crown, okay? And this is the result. You can compare it on the left and on the right. You can see also a good healing in terms of the soft tissue. So we have enough keratinized tissue and amazing healing. And this is the final X-ray. You can see this switching platform. So we have a better seal, we have the bone on the neck of the implant. So this is one option for using this implant. Another case, again, in the mandible, immediate implant placement in the molar area. Have a look at this case. We don't have bone septum. Or I mean, we have very, very thin bone septum. But using this implant with aggressive treats and placing 2 millimeters below the bone, also in that case, we can place the implant and we can achieve a good primary stability. Have a look here. 4.2 per 11.5 in the center of the bone septum. So we can place 2 millimeters below and we can achieve a good primary stability. After that, the protocol is the same. You can put the healing cap, or you can put you can avoid the healing cap. It depends also from the stability, but anyway, we need to fill the gap with the bone. So after 3 months later, we have the healing, and we can put the healing screw. Okay, and we can take the impression with a dedicated scan body for ion connection for the temporary, in order to have this shape and in order to guide the healing of soft tissue. Have a look. This is the T-base with the temporary crown in PMA with this switching platform shape. So we can put the temporary and we can weigh the healing. you can see on the left, when I removed the healing cap, we have already a good healing. The healing and the quality of the tissue is nice, but I want to increase more the thickness of the soft tissue. That's why we need to put the temporary to wait the healing, okay? This is the X-ray with the temporary crown. And again, have a look. The 1 month later, the healing of soft tissue. This is amazing. And this is the final screw with the crown with conical tip base. And have a look, the final crown. What we can see? We can see a good quality and quantity of soft tissue. The aesthetic is nice, but the important thing is to have enough keratinized tissue to protect our implant. And for sure, we can use, again, this is the X-ray and the final view. For sure, we can use also in the aesthetic zone. In immediate implant placement in aesthetic zone, have a look at this case. We have a problem, we have a fracture on the lateral incisor in this young patient. So there is no way. If we have the vertical fracture, the only way is the extraction. So there is no way. In that case, we need to remove this lateral incisor, okay? And after the extraction, we have this situation. For sure, we need to have the OPG, but for sure, we need to have the CBCT to understand the bone shape. Then we can check the depth of the bone. Then we can decontaminate the socket with the piezo surgery procedure, because this is immediate implant placement. So I want to remove any kind of infection, any kind of tissue inside the socket using the piezo surgery procedure. Then we can put the ion implant. You can see here, this ion is 3.5 per 13 millimeter. As you can see, the placement is a little bit palatal. And then, as usual, we need to fill the gap between the implant and the bone using some material. Why? Because we need to hold the tissue, we need to hold the volume in terms of the hard and soft tissue. Then, considering that we can, in this case, we have more than 35 Newton, and as you know, in order to make the immediate restoration, we need to have at least 35 in terms of Newton, in terms of the primary stability. Here we have more than 35, so we can take immediately, using the scan body for ion, the impression for the immediate restoration. And this is the CBCT. You can see the implant placement is palatally, and we have more than 2-3 millimeter on the back side, and I fill this gap using the material. This is the CBCT post-op, and this is the temporary 2 days later. This is the temporary restoration 2 days later. So after 2 days, we can see again the patient. This is the healing only 2 days later. So we can remove the healing cap and we can put the temporary. This is only 48 hours later. After the extraction, immediate implant placement, impression, and 2 days later, we have the temporary. Temporary restoration without occlusal loading, because this is immediate restoration and not immediate loading. So we have the temporary, immediate temporal restoration without loading. And this is the X-ray. Have a look. We have this switching platform, and I put the implant 2 millimeters below the bone. So we can allow a complete healing around the neck of the implant. Putting 2 millimeters below and having this switching platform, we can enter in the conical connection without any problem. And this is the T-base with the temporary crown with the immediate restoration. Only 2 days later, okay? Then we can wait and have a look the healing 4 months later. Okay, this is an amazing, but also is very interesting to see the osseointegration, but also the volume. Have a look, the placement of the implant and the amount of the tissue that we can have on the buccal side. So, especially in the aesthetic zone, is mandatory to keep the same volume. So another option, another indication of the ion implant is in the aesthetic area in order to achieve this result in terms of the osseointegration and in terms of aesthetic. But also we can use in the full mouth rehabilitation using, and I will show here, this new kind of multi-unit abutment. Because as you know, if we are placing full arch rehabilitation, many implant, and if you are using, for example, the all-on-4 concept, we need to use the multi-unit abutment for the prosthetic part. And here we can see how we can use the ion, how we can achieve with ion a good primary stability, and how we can use the multi-unit abutment. Have a look at this case. We need to treat the upper jaw. This patient, he has already the restoration in the lower, but now this is the OPG and also the CBCT. You can see here the huge bone resorption, especially on the right side in the upper jaw. And this is the intraoral view on the upper. You can see the infection that we have. So there is no way. We need to take out all of them. So we need to remove all of this. This is the situation before on the right and on the left side. So after the extraction, we have this situation. We need to open the flap and we can see this huge bone defect and we need to manage it. So this is the occlusal view before and after. As usual, in that case, we need to find the bone a little bit palatal, and we are planning in this case to use 4 implants for full mouth rehabilitation. So we are planning to place 2 implants in the posterior, 2 long implants, 16 millimeter ion, to achieve the primary stability on the residual basal bone, and 2 straight implant ion 30 millimeter in the frontal area. So in that case, we will use all-on-4 with ion connection, okay? Using 2 tilted implant in the posterior and 2 straight in the anterior, using 2 multi-unit abutment 30 degree in the posterior and 2 multi-unit abutment 17 degree in the anterior. Then we will put the healing cap, we will make the suture, then we will take the impression with the scan body, with a dedicated scan body on the top of this ion. Then we can make the immediate loading. But let's see how we can manage this case. After the extraction, we need to open the flap. And according to the CBCT, we will find a huge infection, especially on the right side. And we need to manage this area. So we need to clean everything. And we need to find the bone in which we can place correctly the implant. Okay? That's why it's mandatory to open completely the flap on the buccal side and also on the palatal side in order to see everything as usual. So slowly we can open the flap with the full thickness approach using trapezoidal flap, and here you can see the huge infection that we have. So we need to open more and we need to clean this area like this. So using the blade, we can cut the soft tissue in order to see the bone and in order to clean everything, okay? Because in this area, we want to place 2 implants in the straight area. But at that time, you can see that here we have an important bone resorption in terms of the eye, and we can see the nasal cavity in the anterior, okay? Have a look, the infection, the infected tissue that we have. So we need to clean everything. Also, this surgery, as usual, has to be done in conscious sedation, because with the conscious sedation, as I told in the previous webinar, we can control the anxiety, we can control the bleeding, and we can manage better our surgery. You can see here the infected tissue that we have. So we need to clean everything, and we need to see better. At that time here, you can see the nasal area, okay? So we are in the nose here. So we have enough bone in the thickness, but we don't have enough bone in terms of the height. So we need to clean more. This view is not enough. So we need to complete our surgical procedure as usual, making a sutures in the palatal flap, in the palatal side, sorry, in order to hold the tissue. So we can see the bone on the buccal view, from the buccal view and from the palatal view. Then we can start to place the implant. And in that case, I use it in the posterior 3.75. And in order to achieve the primary stability, we need to reduce the implant section. Otherwise, we can lose the primary stability. So don't forget this concept. In the maxilla, we need to under-prepare the implant site. In the mandible, instead, sometimes we need to prepare more. Why? Because we have a cortical bone, we have a D1 bone. So there is more cortical bone, and we need to prepare more. So now the surgical view is much better, but we need to complete this procedure, removing the bone, performing the bone reduction to place the implant at the same level. For the prosthetic point of view, is mandatory to make the ostectomy, okay? We need to remove the residual part of the infected tissue. We need to clean everything, okay? You can see here the nasal cavity. So here we have the nose. This is the nasal membrane. That's why we will place the straight a little bit on the lateral side to avoid the nasal cavity. And here we will check, and we can see the nasopalatine canal, okay? After that, we need to make the bone reduction, because we need to place the implant at the same level, okay? And you can use the piezosurgery procedure, or you can use the bars to remove the bone in order to have the same bone level, exactly like this, okay? Here we don't have problem in terms of the thickness, we have a problem in terms of the height, because in the posterior we have the sinus, okay? So after this procedure, we can start with the implant placement. But we need to complete before the ostectomy. And as you can see here, we have the nasopalatine canal. So with the retractors, with the periostele, we need to protect this anatomical structure. Now the bone reduction is completed, so we can start with the implant placement, preparing before the posterior, then the anterior, okay? Is almost completed. We need to clean the residual cavity. You can see here the nasopalatine. Now we can see better. The nasopalatine is there. So with the pencil, we can mark the anterior wall of the sinus, then we can start. So we are using the same kit that we are using for I5 or I55. This is the pilot drill, just to cut the cortical bone. Then with the second drill, we can fix the final length. It will be 16 millimeter. This is tilted implant following the anterior wall of the sinus. Then with the pin, we can check the inclination in order to check if everything is okay. Then we can go ahead with the next one, following the same length and the same direction. Okay? We can check the length, more than 60 millimeter. The next one, you can see here. And then we can put ion. This is 3.75 per 16 millimeter. Okay, have a look the primary stability. Have a look the threads of this implant. Here we are more than 35 Newton. So then we can complete manually. But have a look the primary stability. Okay. The different thing is the prosthetic tool, because we have a conical connection. So just to change this, but we can use the same kit. And we can put below the same sequence on the left side, using the red one as last drill. Then we can place the same implant, ion 3.75 per 16. You can see the threads of this implant. And have a look how we can have the primary stability. Then we can finish manually. Okay, now we need to prepare the anterior side. A little bit lateral, because in the frontal we don't have enough bone. Second drill, pin, opposite side, same sequence. $30 millimeter of length, so we can prepare more. We can check the direction like this. And we can continue. Placing ion 3.75 per 13 millimeter in the frontal area. Under preparing the implant site to increase the primary stability. And have a look, the implant is 3.75 per 13 millimeter. Have a look, the good primary stability. Okay, then we can finish manually. Same implant. Okay, then we can finish manually. Okay. You can see 2 millimeter below the bone. Then here we can put the multi-unit abutment. So 17 degree in the anterior and 30 degree in the posterior with switching platform shape, 17 and 13. Then we can put the healing cap for multi-unit abutment for ion in order to make the sutures, okay? So we can remove the sutures on the palatal side. Here we have more tissue, so an infected tissue. So we can decide to remove this one, or you can use sometimes, we can use also this amount of the tissue, but in that case I prefer to remove because it's infected tissue, and also because we have enough soft tissue. Then we can close using the healing cap for a good closure. And after that, using the scan body for ion, for multi-unit abutment, we can take the impression, okay, for immediate loading. Starting always in the middle. This is vertical modified mattress to hold the tissue around the healing cap, exactly like this. Okay, this part is very important because now we will fix the soft tissue, and now with the suture we will guide the healing of the soft tissue. Okay, so this is not single nodes, but this is a vertical mattress to hold the tissue exactly like this. You can see here, because we want to have enough keratinized tissue in this area. Then we can remove the healing cap, and we can put the scan body for ion on the top of the multi-unit abutment, like this. Okay? I already took before the impression, before the extraction, to fix the vertical dimension. Now I need to take another impression only on the scan body, like this, and that's it. So we can send our file to the dental lab for the immediate loading. Okay? We need to complete the impression. Okay? So this is the resume, healing cap, scan body, occlusal view with the scan body and the healing cap, and have a look the healing 3 days later. So after 3 days, we can see again the patient. We can remove the healing cap, and you can see here the healing of the soft tissue. And then this is only 72 hours later. Then this is the temporary. This is the T-base for multi-unit abutment, and this is the temporary. So after 3 days, we can receive the temporary. This is our temporary restoration in PMA with only 4 implants, without cantilever. You can see the emergence is on the first molar. So we don't have any cantilever. You can see here the emergence. Okay. And this is the occlusal view. "72 hours later, we can put the temporary, like this. You can see the healing of the tissue. Okay? Now, just to control the occlusion and to screw the temporary. Okay? And this is 3 days later. Okay? With the temporary. So immediate loading. Okay? So now for 6 months, sorry, we need to keep the temporary for the osseointegration. Okay, so this is the temporary. Lateral view, 3 days later, right side and left side. okay? And this is the X-ray. So, 4-ion implant with the temporary, and you can see the shape of this multi-unit abutment. Okay, this is 3 days later. And this is the healing 6 months later. You can see the occlusal view 6 months later when I removed for the first time the temporary. You can see this shape, especially in the posterior. Have a look the amount of the keratinized tissue that we have around our multi-unit abutment. This is something different compared with the normal multi-unit abutment. Can you see that we have this grow above the soft tissue? This is important for a long-term survival. That's why using this multi-unit abutment, I think in this kind of rehabilitation, we can increase our success in terms of the soft tissue healing. Okay? This is 6 months later. Then we can go ahead with the final restoration. It's very easy now. Just to take a new impression for the soft tissue. This is the bar inside, and this is the final restoration. So the final restoration, it will be a Toronto screwed in ceramic, okay? With only 4 implants. And this is the final result, okay? Screwed ceramic Toronto on ion. This is the final view. This is the occlusal view. And this is the lateral view after the final restoration, right side and left side. And this is the final video of this restoration. Okay. This is made in ceramic. Okay. So as you can see, we can use ion in the single implant, in the aesthetic area, and the full mouth rehabilitation. The important thing is to place correctly the implant. So it's better to place below the bone. And in this kind of rehabilitation, using the multi-unit abutment, we can have for sure a better healing for the soft tissue. And this is the final X-ray. You can see that the bone is very, very stable. Okay? So I think now we're finished this short lecture, but through these clinical cases, we can understand, I hope, how we can use the ion in our daily practice. So with AB Dental, we have the possibility to choose different implant shape. And this is amazing for our point of view. Why? Because we have different implant for different clinical situation. Okay? And don't forget that we need to follow the protocol. So for ion, we can use the same kit just to change the prosthetic tool. The protocol is a little bit different because we need to place the implant below the bone. Instead, I5 or I55, for example, in which we need to place the implant on bone level. Here, we need to place the implant below the bone. This is the difference, okay? So thank you very much, and if you have any question, please feel free. So we can open now the discussion about this topic.
Okay, so first of all, thank you very much, Professor Cardarelli, for sharing your experience and knowledge with us. This cooperation with you is very important for us at AB Dental, and we appreciate it very much. I want to remind you all to enter our events portal. You have the link in the chat, and you can register for our upcoming events and check all the information and links to register over there. We are now going to get to the questions and answers sessions. So if anyone have any questions for Professor Cardarelli, you can write it on the chat, and he can answer the questions. Anyone have any questions for Professor Cardarelli? Okay. If no questions, though, we can finish. But if anyone wants to ask any questions, you can do it right now.
So we can wait some question about this. I don't know if they are using already this implant, if they have some experience about Ion. So if you have some experience, we can share our feedback in order to.
Okay, here we have a question from Ellen Espinosa Estrada. Do you use any kind of tracers?
Any kind of?
Tracers? Trackers?
What?
We don't really understand the questions.
Yes, exactly. I don't understand.
Ellen, can you ask again?
Tracers, what do you mean for tracers?
Fiducial markers.
What? I don't know. I don't understand. So
Any other question, anyone?
you place them?
For scan.
Can you explain better? Because really we can understand your question. I don't know. Fiducial markers, what do you mean? Do you mean a surgical guide? No, this is not surgical guide procedure. This is open flap. I don't use any reference. This is the open flap procedure. So then after the implant placement, we can use the scan body and that's it. But I don't use any markers if you mean that. No CBCT for the diagnosis, but no CBCT for the surgical guide because this is the open flap procedure. So I don't use any kind of markers, if I can understand your question. For the impression, this is a right question. No, I don't use any kind of reference. Why? Because I can take the impression before the extraction using the impression of the palatal side. So if I can scan before the extraction the palatal side for the whole extension, we can match the previous scan with the second scan, and then we can recognize the two impressions. The important things, as you know, in the digital impression, sometimes the edentulous patient, it's not easy. That's why before the extraction, you need to take the impression about all palatal area, also in the tuberosity. Then with the scan body, we need to do the same, starting, for example, from the tuberosity, so the program can match the previous impression with the second impression. Now I understand.
Okay, thank you. Nice talk. Anyone else have any questions for the professor? Dear professor, upper low implants looks like they are inside of the sinus. Why are you use so long implants? This is the question from Marcin Lodzik.
Okay, I will explain for sure. If you see the surgery, the OPG is not the real. It's not the real X-ray, as you know, because this is a bidimensional. But using the open flap, you can see when I put and when I prepare the implant, we are in the body. You can't see if the implant is in the nose or not using the OPG. You need the CBCT or you need to fill using the implant site preparation. The implants are on the palatal. So if you see the the OPG, you can see the implant in the nasal area. Why? Because this is the overlap, are in two different levels. So if you see the OPG, this is the overlap, but the implant is not in the nasal. And why long implant, especially in the posterior? Because, as you know, in the maxilla, I need to achieve the bicorticalism and I need to achieve the primary stability. So with the posterior implant, with the length of the implant, I need to achieve the primary stability here on the nasal basal bone, where the quality of bone is very high. If you tilt the implant and you're using, for example, 11.5, there is no reason to tilt the implant. Because now in the maxilla, we are tilting the implant to avoid the sinus, but to increase the contact surface between the implant and the bone, and in order to achieve the primary stability in this area where the bone is D1. This is the reason.
All right. Any other questions? Karen, Gutierrez, Melendez, right? Thank you. Thank you, Karen.
Thank you.
Anyone else wants to say anything?
Any question? See you in Greece for sure.
Zhao asking, how about lower?
About lower, what do you mean? Lower what? Can you explain better so I can answer you? If you mean the bicorticalism, for sure in the mandible it's different, because as you know, we can achieve the bone here in the lower side of the mandible. The bicorticalism we can have in the maxilla.
Is asking, yeah, how many implants will you place for full mouth rehabilitation?
I will answer this question in the next webinar next week. But anyway, just to answer you, it depends. Sometimes minimum we need to have 4 implants. If you have more bone, we can place 6. So at least using 4 implants till 6 implants. It depends the amount of bone that we have. But I will explain how we can treat the atrophic jaws using different number of implants in the upcoming webinar next week.
Okay, thank you, Professor. So we very much invite you all to register right now to the upcoming webinar next week, which is going to be all on X concept. Here you have right now the link. You can register for next week. Any other questions? Anyone? Thank you for your knowledge shared. See you in Greece. Jose Arroyo says that. Regards from Portugal.
Thank you very
See you
much.
in Greece.
For sure, see you in Mexico also in September.
All right. Regards from Myanmar with us tonight, all
Yes,
over the
for sure.
globe.
See you in Mexico and in Guatemala. In Guatemala, we will do also a course on customized implant.
Mr. Moshe Baylor says thank you.
Thank you very much.
All right. So I think we are done with the questions. Thank you, everyone, for participating here with us tonight. Thank you, Professor Angelo Cardarelli, once again, for the wonderful webinar and sharing your knowledge. And see you next week, everyone. Have a great evening.
See you next week. Don't miss this amazing webinar next week. See you next week online. Bye-bye. Thank you.
Bye-bye.